can you talk your full name and a little about yourself?
Okay, thank you so much. First of all, thank you for the invitation and for having me here. It's a pleasure to be for the first time in South America and Brazil in particular. I appreciate being here. And then a little bit about myself. So my name is Daniela Moga. I am a professor at the University of Kentucky in the College of Pharmacy and also with a joint appointment in the College of Public Health in Epidemiology. And my research is mostly around geriatric pharmacoepidemiology, use and outcomes related to appropriate and inappropriate medication use, so looking at risks and benefits, and then deprescribing medications is part of my portfolio and one of my interests.
Okay, thank you. The first question is, what strategies have proven most effective in promoting the safe deprescribing of sedatives and opioids in older populations, particularly those with multiple comorbidities?
I think the key here is to really consider the patient, the individual patient, and looking at the whole picture as opposed to just focusing on whether or not they are using opioids or sedatives you mentioned. And we know that these medications have the potential to cause withdrawal symptoms if they are stopped abruptly. So I think key in prescribing these medications and getting acceptability of the patients is to consider a process of reducing the dose, tapering the medication to achieve the goal of stopping, if that is the appropriate course of action for those patients. So never like stop without any consideration for potential side effects of stopping, but rather taking it slowly and adapting to the response of the patient. So it's a little more work, obviously, but I think in the long run that turns to be more effective. And really engaging the patient so they understand the reason behind the process.
Okay, the second question. How can real-world data help identify patterns of inappropriate use and support preventive intervention to reduce risks associated with long-term sedatives and opioids use?
That's also a very good question and kind of complex and hard to tackle sometimes with real-world data. You mentioned inappropriate use, and then I think it's a key term that is used there. And how do we define appropriate versus inappropriate? That sometimes is impossible to really tell from real-world data. So we need to think, how do we define? Is it based on multiple medication use that bring the potential for drug-drug or drug-disease interaction, and that would be an element to really capture, which gives you a little more granular evaluation than just to say use for, I don't know, 3 months versus 6 months, these cutoffs that sometimes seem arbitrarily. Sometimes you have to consider, does the patient even need to start on the medication? So when you think in terms of prevention, is it really about stopping after it's started, or is it more, does the patient needs it to begin with? So you asked about measuring, and I think it's, volume of use, a lot of the drug-drug or drug-disease interaction, and the potential for polypharmacy in terms of inappropriate medication use.
Okay, thank you very much. You are just amazing.